Good morning everyone and welcome to this 6th week. I hope all of you are enjoying this course, and as we are in week 6, there were lots of assignments and homework assignments. I hope you are completing them within the given time limits. For the homework assignments, as we have told multiple times, that it doesn't have any time limit, so please take some time out to complete it as you go along this course, so that towards the end there will not be any extra burden. As far as the weekly assignments are concerned, so that you can do immediately after finishing the weekly clinical contact session. So like every time, this week also we had 2 lectures from University of Washington faculty. One was, the topic for this week is post-exposure prophylaxis and preventive care. So we had 2 sessions on that. One was on HIV pre-exposure prophylaxis and all issues related to it, and post-exposure prophylaxis, and a small note on treatment as prevention. So in this particular session, or for this particular topic, there are various things which are unanswered. So we don't have answers to every question. So we will keep that in mind before we go ahead in this session. So in the practical scenario where you work at ART centers, and also where anyone does the clinical practice, you will come across many situations where you will not be able to give a definite answer. So we'll try to find out those gray areas while we go along in this session. I hope all of you might have listened to those 2 lectures done by the UW faculty. So this will be a kind of revision, and also we will try to revise the national guidelines on this. Now there are some areas on which our national guidelines is silent. So we don't have anything about, for example, pre-exposure prophylaxis, treatment as prevention. Now very recently we have the strategy of treat all for many of our patients, strategy of treat all enrolled, which has been enrolled now in the national program. But pre-exposure prophylaxis is something which is not in the program and may be new for some of you. Others might know about it. The post-exposure prophylaxis is something which all of us are aware, so we'll be revising that part also in this session. So if you have any questions related to that also you can type. So after all this, I think it will be good to mention here itself that we will be following NACO guidelines while working at ART centers. At no circumstances we will be, because see, some of the things mentioned in this session will be for knowledge as of now. As and when NACO revises guidelines, so we need to stick to those guidelines only. So there should not be any confusion after this session that this was recommended, or this is being recommended by others. Those all things are good to know, but towards the end while working at the ART center, we need some guidance from NACO, and there will be a national policy which will be implemented throughout the ART centers uniformly. So we have post-exposure prophylaxis, but it is for occupational exposure and post-rape victims, but not for the others like sexual exposures. We don't have it in the policy, in the program guidelines. So what I'm trying to get at is we will try to get ourselves updated on the recent issues or recent areas in which ART is involved, but end of the day we will be following NACO guidelines. So let's start with the session content. There are 2 major prevention strategies, HIV prevention strategies, if we want to categorize them in these 2 heads, that is ARV based and non-ARV based. For non-ARV based, we have behavior change communications, which means if someone is having high risk behavior of acquiring HIV infection, we can work on those behaviors and we can reduce the risk of HIV transmission. For example, if someone is not using condoms and having multiple sex partners, then we can change that behavior to a safe sex behavior where a person will be able to use condoms when having sex. Similarly is the clean injection equipment, where in our program we have a program for needle exchange program for intravenous drug users. So that is one of the prevention strategies of HIV. Similarly, male circumcision and in HIV testing and male circumcision. Male circumcision is something which is not in the national program as a policy, but benefits of male circumcision is very well known. So it reduces risk of HIV transmission by 60% by some of the very common studies which are quoted. So, but because of some reasons, it is not a national policy here. But 60% risk reduction is a big thing. Then similarly, STI testing and treatment or vaccine. So these are some of the non-ARV based HIV prevention strategies. But there are some ARV based treatment strategies also. Before ART or ARVs came into the market, we only had these things to protect someone with or from HIV. But after ARV or became available and ART was rolled out, especially as a national policy, there are many evidences on the basis of which you can say that because of the treatment, it has been one of the best strategies for HIV prevention. So if you put someone on ART, it will reduce that person's viral load below detectable level, and then there will be a very less chance that that person will be able to transmit HIV virus. So it is called nothing but as treatment as prevention. We'll come to that part towards the end, where we'll be having a couple of slides on what is the evidence behind this. But with rollout of Treat All in the national program also, you will be able to see that one of the major driving force behind this policy has been that if you treat everyone who is HIV positive with ART, then you will be able to suppress their viral load to below detectable level, so that they will not be able to spread HIV. And if you look at the public health perspective of this, it will help you to achieve the epidemic control. That means the number of new infections will be less than the number of deaths of HIV positives because of HIV. Now there are again under ARV based HIV prevention strategies. If you see, you have TASP, that is treatment as prevention, and pre-exposure and post-exposure prophylaxis, and mother-to-child prophylaxis, which we give in our PPTCT or PMTCT program. So now we are having Treat All in the national program as well. When we were talking about the ART session in the last in a couple of weeks back, then I think we were discussing about guidelines for less than 500. But as you recently might have received a communication regarding Treat All, that has been rolled out. But again, and also we have received letters from NACO. So that is one of the policy which we need to be working on. So as directed by the State AIDS Control Society, we will have to implement that policy in your ART centers with the availability of medicines and everything you need to look at, and then you need to implement that policy. Now let's start with what is PEP and what is PrEP. For some people it may be new, that is PP everyone knows, which is called as PEP usually, and pre-exposure prophylaxis, it is the short form used for this is PrEP. So as the name suggests, post-exposure prophylaxis is you have one exposure here, and after the exposure you give medicine so that a person is protected from HIV virus. So this is usually 28 days medicine. That is a limited course of ARV medicines is given in these people. So that is exposure has happened here, and after the exposure, the post-exposure, you are giving ARVs for a limited duration of time. In pre-exposure prophylaxis, this duration is not known for how long you are going to give the prophylaxis, but there can be multiple exposures at various time points. So HIV medications are to be prescribed for a longer duration of time in people who are having high risk of HIV exposure. So if there are multiple exposures of in multiple and repeated exposures, then the person who is HIV negative is given antiretroviral drug, so that the drug levels are maintained in the person's body, and for which the good adherence is required, so that whenever there is exposure with HIV virus, this person is protected from HIV. That is nothing but a pre-exposure prophylaxis. So if you want to describe this again in better words, it is a prevention strategy in which there are three things which have been highlighted here: high risk, regular, and risk reduction strategy. So this is a prevention strategy in which a high risk individual, that means it is given to a person who is at high risk of acquiring HIV, not to everyone, and the person takes medicines regularly. We'll come to what regularly means. Is it every day, or it is like once in 2 days, once in 4 days? What is this regularly means, that we'll discuss in future slides, along with the continued behavior risk reduction strategies. So this is not a standalone strategy. Pre-exposure prophylaxis is not a standalone strategy that is given to everyone and anyone. So it is, first thing it is that it is given to a person who is at high risk of HIV. Number two, the person has to take medicines regularly. That means adherence should be good, and also it should be kept in mind that it is not a standalone strategy for HIV prevention. It has to be accompanied with behavioral risk reduction strategies, for example, condom usage and other things. So the drugs which are used for pre-exposure prophylaxis, which has been approved by US FDA in 2012, is a combination of tenofovir and emtricitabine. We had discussed about this emtricitabine also, that this is very similar to lamivudine. The common trade name there in US is Truvada. So tenofovir-emtricitabine combination is the approved combination which is used for pre-exposure prophylaxis. There is some additional benefit for this also, that it has also activity against HSV, herpes simplex virus, and HBV, that is hepatitis B virus. Now coming to the efficacy of this combination, that is tenofovir-emtricitabine or individual tenofovir as drugs for pre-exposure prophylaxis. So the resource person of UW, while in his lecture, he has actually summarized this beautiful table for us, where he has mentioned all the studies related to this topic, and in which you will be able to see at one glance a comparison between the studies and the impact of this strategy in each study. So in iPrEX OLE, that is first study, if you see, which was done in Brazil and other countries, which was done in almost 2,500 MSM and transgender women. So in this population, there were two groups were made, that is daily oral tenofovir-emtricitabine, and it was compared with a placebo, and a combination of tenofovir and emtricitabine was given, and the impact or the effect on HIV incidence was that it reduced the risk of reduced the HIV incidence by 44%, which is very, very good and very high. Similar study was done in partners of that is called as partners PrEP study, was done in above 4,000 heterosexual HIV discordant couple. In this discordant, and as you all are aware, that discordant couple means one person of the couple is HIV positive, another one is HIV negative. So it was kept in mind in the study also that there is equal balance between male HIVs and female HIV partners in the discordant couple, so that it is equally distributed. So again, in this daily oral tenofovir or in combination along with placebo was used for randomization. Then it was observed that in tenofovir group, the HIV incidence would reduce by 67%, and a combination of tenofovir and emtricitabine, HIV incidence reduced by 75%. Similarly, other study, that is what was done in Botswana, that is TDF2 study, where in heterosexual men and women, more than 1,000, that is more than 1,200 in fact, was used, and similar results were seen, that is the HIV incidence was reduced by 63%. There were a couple of studies though here, if you can see, that is FEM, that is female PrEP, and voice, where you, and also the number of study population is again quite big, but here there was no protection was seen. We'll come to that, these two studies in the next slide, why it happened that there was no protection, while the other all studies, if you see, there was very good protection, which was like Bangkok study, iPrEX, and then PROUD study. All these studies will show that HIV incidence has considerably reduced with usage of pre-exposure prophylaxis. Now, we had mentioned one point in the last slide also, that adherence is crucial if you want to see good results. So this slide will show the results which of all these studies as it was in comparison, and also the adherence of the people to antiretroviral drugs in this study. So in these two, except these two studies, all these studies where the results were good, and here you saw that results were not good, like this female population. Now, why this happened towards later on, what they did was they took out this. They took out the adherence evidence. So like they monitored adherence actually by measuring the blood levels of ARV medications. So when they saw this in these two studies, it was observed that adherence was either very low or it was zero as well. Now, why that happened and why this did not happen in other studies, later on when they tried to study this, it was because of the stigma of ARV medications, which will, if a person is keeping or if a woman is keeping HIV medications in his or her home, that itself was believed to be a stigma, that being HIV negative, if someone is taking medicines, then people might think that that person is HIV positive, in fact, and that resulted in stigma, and which landed up in with the women not taking the antiretroviral medications. So this was the main reason why this did not work. Otherwise, in all studies, if we see earlier, PrEP worked very well. This can be further explained with this slide. If you see efficacy versus adherence, as and when adherence increases, efficacy of PrEP increases, and that's what was shown in other studies like Partner PrEP, PROUD, or TDF2, Bangkok, and iPrEX. So all these studies show that PrEP is very beneficial in those people who are at higher risk of acquiring HIV infection. Now, regarding the adherence, whether everyone has to take it every day, or it is okay if someone is taking these pills at infrequent timings also. So in this study of which is iPrEX OLE, which enrolled 1600 plus MSM, where 76% chose to receive PrEP, and adherence was measured by random blood sampling, where on a filter paper or dried blood spot, level of TDF were measured, and it was seen that if HIV incidence reduced if a person's adherence is good, but if HIV incidence was again zero, even if a person is taking 4 to 7 tablets per week. That means that in men, actually, if you look at men, they need not take a PrEP tablet. As per this study goes, men need not take PrEP tablet every day. 4 tablets a week may be sufficient for them to have this prevention against HIV virus. But again, this has not been studied in women, whether it is okay in them or not. Reasons we don't know, as I started in this session, that most of the questions will be unanswered as far as this topic is concerned. But as far as this study goes, it says that even if a person who is male and is taking pre-exposure prophylaxis 4 tablets per week, that also is enough for him. But again, while advising, we don't advise people to take 4 tablets a week. It is like 7 days a week, that is 1 tablet every day. Now, we all know regarding the PrEP or the side effects of tenofovir and combination of tenofovir-emtricitabine, that is PrEP side effects. We studied this in the last session also. But just to again refresh your memory, there is something like startup syndrome, where when we initiate any treatment, like very commonly, and we see this with antibiotics, similarly with tenofovir-emtricitabine combination, nausea is a common startup syndrome, and other symptoms like headache, fatigue may occur in the first 2 to 4 weeks. But these generally resolves with over-the-counter medicines or the general medicines like NSAIDs and antacids and all. But there are two important toxicity or side effects or adverse effects of tenofovir which have to be considered, like renal toxicities and bone marrow effects. We all know that tenofovir is nephrotoxic, and that is why in the first 3 months we advise a person to undergo renal functions, and then after every 6 months that is repeated, at least serum creatinine we advise. And as it causes bone mineral deficiency, we have in these studies also it has been seen that there is no increase in fractures, but tenofovir causes these bone mineral deficiencies, or it causes reduced bone mineral or bone density, in fact. So these things need to be kept in mind while we put the person on PrEP. One more thing regarding ARV resistance, because we have always at the back of our minds that when we give antiretroviral drugs to someone, will it cause resistance, or will this treatment be beneficial in future? So if you look at all these studies and compare these two, that is infected at the time of entry and incident infection, that means if a person is already infected at the time you initiated PrEP, and which can happen because of the window period, because you did HIV testing in the beginning, but as a person was in window period and did not take ART, and HIV was not confirmed, you went ahead and initiated ARV in that person, and later on you found out that that person is actually HIV positive since beginning. So as this person was on 2 drug medications, that is tenofovir-emtricitabine, if you compare the resistance in this with a person who acquired HIV during the course of PrEP, then you can see here almost 40% of people will have resistance to tenofovir and emtricitabine, and here only 3% will have. That means if you have this take-home message from this slide is, first thing is you will have to rule out HIV in the best way possible before putting someone on PrEP, and then if someone does not have HIV infection and at that time and also is at higher risk of acquiring HIV, and if put on PrEP medications, then the chance of getting resistance to those medications is very low. So, and then other thing is, if you are suppose giving PrEP to someone, does it increase its sexual risk taking? That means if you are we think about similar phenomenon when we talk about needle exchange program, that if you are giving needles to those who are injecting drugs, so are you encouraging injection drug use in them? Or similarly with condom promotions, if we promote usage of condom, are we encouraging people to have multiple sex partners? So that is sexual risk taking, in fact. So similar questions are asked regarding PrEP again, that does it increase the sexual risk taking or not? So we have an evidence that in fact the sexual risk taking it has reduced in these 2 studies. If you see, that is in both iPrEX and partner PrEP studies, condomless sex became less common over a period of time. But why this happened is because these are all controlled settings when all these medication, that is PrEP, was given along with other risk reduction strategies that people used to visit facilities frequently, like quarterly or 6 monthly, where you explain them regarding risk reduction. You continue with the counseling of condom usage and other risk reduction strategies. All those things were done along with medications. Like I mentioned before, that this is not the standalone strategy, but it is accompanied by the other risk reduction strategies as well. So those things help, but you might ask question that that as it is in controlled settings, and also people did not know whether they were receiving PrEP or placebo. But again, this after the study was complete, and after everyone knew that who is taking PrEP and who is taking the placebo, then also it did not increase the risk-taking behavior. It remained actually same before and after usage of PrEP. It has other benefits, which are social benefits. If you think in terms of from the patient's perspective, it has reduced anxiety. See, a person, if he or she is HIV negative and having a sex with HIV positive, there will be always an anxiety of acquiring HIV infection. But if the same person is on PrEP, it will definitely reduce that person's anxiety because he is on some protection. Then also it increased the communication and it made the disclosure easier for a person who is HIV positive, because then you have something to offer to the HIV negative person to remain HIV negative. And also it added to the increased self-efficacy, intimacy, and also pleasure. Because again, if you don't have that anxiety, if a person does not have that anxiety of acquiring HIV infection and always has that feeling of protection, then it is definitely going to help the person who is HIV negative. So there are CDC guidelines on this, how to issue, how to give or how to use pre-exposure prophylaxis. These guidelines were released in 2014. There is no revision after that. So who should be considered for PrEP? Everyone? Answer is no. So individual who are at substantial risk of HIV, they are offered or they are considered for PrEP. So a man or woman in relationship with HIV positive partner, again in this relationship also, if you think on it, then the positive person, whether is on ART or not, that is an important consideration to be made. Because if a positive person is already on ART and his or her viral load is suppressed to the level which is below detectable level, then the risk of transmission is anyhow very low. So that factor is very important, and which will play an important role to decide whether a person should receive PrEP or not. And as I mentioned before, this is not a standalone strategy. The other risk reduction measures will have to be continued. Then gay or bisexual men not in mutually monogamous relationship and not using condoms 100%, those will be at risk of acquiring HIV and may be considered for PrEP. Then man or woman with recent STIs, man or woman sexually active with high risk individuals, man or woman who use injection drug use or injections, and commercial sex workers, and serodiscordant couple who want to conceive. Now this is again very common scenario which we come across where people or couple, they come to us in our ART clinic saying that we want to conceive, and what is the protection we can use, because if a couple is discordant, one partner is HIV positive, another is HIV negative. If man is HIV positive in the couple, the usual strategies we advise is they can go for sperm washing or in vitro fertilization or IUI or intrauterine insemination. These are the measures. In vitro fertilization is very expensive and is a long process, and but intravenous the intrauterine insemination IUI, which is done after sperm washing, is relatively cheaper, at least in our country. So they can go ahead with that. But again, in addition to that, because in other countries these measures are also very expensive and they are not covered under insurance schemes, so there it becomes very helpful for these couples to use PrEP, especially in those days where they will have to have sex without condoms, where they want to conceive. So in that duration, whether we that is the one of the scenarios where PrEP can be considered. Now these are the PrEP guidelines, CDC guidelines for baseline evaluation before prescribing PrEP. That is, first is you will determine the eligibility, then substantial ongoing risk of HIV infection will be assessed, because of the only reason that we mentioned in the very beginning, that PrEP is not given to everyone. It is given to only those people who are having high risk of acquiring HIV infection. Then it should be given only to those who will be able to take a pill every day and return every 3 months. That is, adherence is very important. Those people who do not want to take pills every day should not be prescribed PrEP, and 3 monthly follow-up at least is very necessary for, again, to check other parameters regarding toxicities and other things, and also to see the adherence. Then screen for HIV before you initiate for ART. We already saw that if you don't screen, then what might happen. So there will be a risk of resistance in those patients. So HIV risk, to the best, HIV screening should be done in the best way possible. But sometimes it is difficult, because if someone is in window period, then we don't have tools to find out HIV infection or diagnose HIV infection in very early phase, especially in them. Even if you use 4th generation ELISA or HIV viral load, for example, if someone is window period, within 7 days there is no way that you will be able to diagnose HIV. Then check for hepatitis B antibody panel, and renal functions also need to be checked. Then prescribe PrEP, Truvada, that is combination of Tenofovir and Emtricitabine, 1 tablet per day is given. Not more than 90 days tablets are prescribed at a time, that is 3 months medications, and also emphasize importance of adherence. Then continued counseling is required, that is continued risk reduction counseling regarding usage of condoms, and then other risk reduction methods are to be advised, and usage of clean needles and all that. So counseling will be very crucial. So, and also it should always be remembered that PrEP is not a standalone strategy. It has to be accompanied by the other risk reduction measures. Then lab monitoring every 3 months, HIV tests need to be done. Every 3 to 6 months, STI screening need to be done, and renal function need to be done, because tenofovir is nephrotoxic. So at least at 3 months, and then every 3 to 6 months it need to be seen. As far as other laboratory parameters are concerned, this is the table just to remind those who are prescribed PrEP. HIV screening, at what duration has to be done, and then HBV antibody testing, serum creatinine, STI screening, and pregnancy test. So which can be done at 3 months, and then again later on also it can be repeated. Now again, as I mentioned before, the recommended HIV testing and screening test, as it was mentioned in this session by UW faculty also, that we don't commonly use oral tests in India. Our HIV screening tests are usually blood or serum based only. So those are the only recommended tests for ruling out HIV infection. So this slide is important for you for just to understand this, and also to answer one of the question in quizzes as well, it might come. So at a minimum, document a negative screening test within a week before initiating or reinitiating PrEP. That is, it should be done before initiation or at least within a week before we initiate. And also, if it is negative or indeterminate, screening result in a patient with recent signs and symptoms of HIV need to be asked. So acute HIV infection signs and symptoms need to be asked, and in those patients this screening need to be repeated after 1 month, and PrEP can be deferred by that time. And you can also send the HIV RNA PCR. So it has to be ruled out before initiation of antiretroviral medications in those patients. But again, there are many questions, as I said before also, which are unanswered and are to be answered. That is, what is the role of intermittent dosing? As I mentioned, as in one of the studies, we saw that even if a man takes 4 tablets in a week, is that okay? And also we spoke about discordant couple, and whether in that phase where they would have unprotected sexual intercourse, is it okay to have PrEP medicines only at that time point, before, or some few days before or few days after that, or it has to be taken up for longer duration of time? So intermittent dosing is one question which is again yet to be answered. Then how soon after a person starts PrEP is protective? That means if suppose you are starting PrEP in someone, after what time he can take risk, or what time later he will be protected against HIV virus. That again is one thing which we can see some data on. Then how effective are other drugs beside Tenofovir-Emtricitabine? Especially people are talking about these days TAF, that is tenofovir-alafenamide, which is very similar to tenofovir, that is TDF. So whether it can be used in place of tenofovir or not, or what is the role of other drugs? So we don't know about it. And also, what is the optimal way to transition from PEP to PrEP? Then what are the benefits for an individual whose partner has HIV with a suppressed viral load? That's what I mentioned initially, that if someone is already in a discordant couple, if a positive partner is on ARV medications already and is having suppressed viral load, as I mentioned before, that the risk of transmission of HIV will be very less. So whether in those couples, in those people, if you use PrEP, what is the benefit of it? Then also, as I mentioned before, is tenofovir-alafenamide is effective for PrEP or not? And what is the other? What are the other safe options if a person already have renal disease? Then regarding intermittent doses, there has been study which show that there is a successful reduction of HIV infection even if you use the intermittent dosing for the PrEP. So Truada, that is tenofovir-emtricitabine combination given before sex, that is 2 in 48 hours after, and it is compared with the placebo. It has been effective in this study which has been shown. And also the other, that is HPTN 067, daily dosing was compared with time driven, that is twice weekly plus post exposure, that is after the exposure has happened, and then even event driven, that is before and after a potential exposure event, it was compared. So if you see that, then 2 tablets 2 to 24 hours before sex, or 1 pill if the most recent dose was taken between 1 to 6 days prior. So if you see this, and after this was the HIV exposure event, and then 1 tablet 24 and 48 hours after the last pre-sex dose. So if and with the caveat that if sex activity continues, then PrEP continues daily until the 48 hours after the last sex. Otherwise, the same process repeated with the next exposure event. And this, the result of this was seen that there was 86% reduction again with this intermittent dosing of PrEP also. Though there was 86% reduction in the HIV infection which has happened with the intermittent doses as well. So it is especially in this study which was done in high risk MSM. And how soon it can be effective? The answer is the time to maximum intracellular concentration with daily oral dosing. It is different from the drug level which is achieved in the rectal tissue and vis-a-vis in cervicovaginal secretions. In the rectal tissues it may be approximately 7 days, and in the vaginal secretions it may be 20 days also. There are various forms in which this drug is used. We very well know here in India we have availability of pills, that is tenofovir-lamivudine or tenofovir-emtricitabine combination. But there are other forms, that is tenofovir gel is used, that is this Truvada gel, and then vaginal film, vaginal ring, and there are some newer drugs which is integrase inhibitor injectable form which might come in future, which is having very long half-life. So that those drugs are investigational drugs and still not in practice. That might come in future. So there are multiple various forms in which this drug is used. If a partner is on PI based ARV, then what regimen is used as PrEP? See, it is not dependent on what regimen a partner who is HIV positive is using. More important than that is what is the viral load of the positive partner. If a partner is on PI based regimen or any other ARV combination, but if the viral load is undetectable, then as we mentioned before, we don't know how effective the PrEP or what is the do we actually require PrEP in those clients or not. So the regimen remains same. As we said, that regimen will be tenofovir-emtricitabine combination, irrespective of the fact what regimen the partner is using. So it is, but if you are talking about the fact that if a partner is who is HIV positive is on PI based regimen because the first line ARV has failed, and if the recipient or the negative partner might have the exposure to HIV resistant virus, then we don't know. Again, as I said, there is again no data to support this, that whether PrEP will be effective in that person or not. So if PI based regimen is used in a positive partner as a second line, because the first line ARV which was tenofovir based has failed, then we are not sure whether this PrEP will be effective in this partner or not. But as I mentioned before also, that if PI based regimen has been used as a first line, and even if used as a second line but viral load is below detectable level, then risk of transmission is anyhow it will be very low. I hope I answered your question. After explaining all this, we should remember that one thing, that PrEP is not being given to each and every one. That is number one. Second one, it is only given to people who are at higher risk of acquiring HIV. Third one, it can be considered in a serodiscordant couple, but more important than PrEP will be what is the viral load of the person who is HIV positive in the couple. So if that person is not on ART, then first priority should be that person should, the positive partner of the discordant couple should receive ART, so that his or her blood level or the viral load is undetectable. Then natural protection will happen. And also we spoke about the intermittent dosing of PrEP, especially in discordant couple where one who want to conceive. We also talked about the other ways which can be used. In the current national guidelines, NACO is silent on the usage of PrEP. There are no any guidelines which talk about PrEP as far as present NACO program is concerned. So we will not be using PrEP as such in the NACO ART center as of now. So, but what we already use is post-exposure prophylaxis. I hope if the others are listening to are able to listen, then there is no problem from my side. I think someone is Dr. Rajesh is not able to listen. Am I audible to others? Okay, thank you. So about the post-exposure prophylaxis, there is no environment actually risk of HIV transmission reported. Why this slide is here is because people usually ask that if what will happen if HIV is outside the body, and then if someone or most commonly asked thing is if a dog bites to HIV positive and then the same dog bites to HIV negative, then will HIV gets transmitted or not? Questions like this will be very commonly coming to you in your clinical practice. We should remember 2 or 3 important issues here. One is HIV is a human virus. It will not survive in animals or others like mosquitoes and all that. So that there will not be any environmental transmission. HIV gets inactivated very quickly outside the body. So HIV does not multiply outside the body, and also it very quickly loses its infectivity once it is the fluid gets dried up. So other infections which have to be considered when we talk about the seroconversion, especially after occupational exposures, that is accidental needle prick injuries and all. So risk of HIV transmission in the occupational or through needle stick injuries, it is 0.3%. While if you compare that risk with the other viruses like HCV and hepatitis B virus, hepatitis C virus, it is 2 to 3% risk of transmission, while hepatitis B virus, it is much more infective. As far as needle stick injuries is concerned, it is 30%. That is 3 out of 10 times there will be a risk of seroconversion. This risk also increases if someone is HBe antigen positive. Why this happens is because if someone is only surface antigen, surface hepatitis B antigen positive, and if HBe antigen is negative, then viral load is considered to be less. And if someone is both HBs antigen, that is surface antigen positive, and also HBe antigen positive, then it is more likely that viral load of HBV virus is more in that person's body, and then risk of transmission is again for the same reason it will be more. So in comparison with HIV, if you see the risk of transmission with the other diseases like hepatitis B and hepatitis C, it is much more than in comparison to HIV. For hepatitis B, there is a vaccine available. All of us actually should take, and also whoever is dealing with HIV positives in the hospital clinics should be vaccinated with hepatitis B virus, because there is a vaccine available for that. And also while taking precautions like universal safety precautions, someone should not take those precautions only if a person is HIV positive. As we very clearly saw in the previous slides, that people may be in window period where you don't know. So if a person is HIV negative, then sometimes it happens that people don't use universal safety precautions. So we should keep all these things in mind, that that a person can be in window period, that is number one, and universal safety precautions will protect not only against HIV but also against other deadly diseases like hepatitis C and hepatitis B virus. There is question or comment, only 0.3% HIV, then why refuse for operative work? Only stigma or any other reason? This is actually good. I'll take this as a good comment. People refuse surgeries on HIV positives. That is very unfortunate to see. And the risk of exposure through needle stick injury is 0.3%. And obviously there is a kind of stigma which is very high amongst even some of the surgeons and other people also, because of which they refuse surgeries. When they very happily do surgeries, people who are tested negative with any antibody test, forgetting about the window period and all. In ideal situations, this should never happen. There is, first of all, the risk of transmission is same even if you do HIV test or do not do HIV test, and if a person is tested positive or negative with antibody test. In fact, if a person is suppose antibody negative and in window period will have much more higher viral load than a person tested HIV positive with in antibody positive might have a lower viral load also. So if a person is HIV positive, then best time to take him for surgery will be when the viral load is undetectable. So that actually is one step which doctors or surgeons can look at, that what is the viral load of a person, so that they'll be having the risk of transmission will be low if the viral load is low. Yeah, the HBS antigen, again the stigma which is related to HIV is not same in our country, which is if you compare that with stigma associated with hepatitis B, but you are right in saying that in fact the risk of transmission of hepatitis B is much more higher than HIV, but the route of transmission of HIV is sexual, and that is main reason of stigma. Viral load is not frequently done in NACO program. Right now the policy is targeted viral load testing in the national program, but NACO is working on scaling that up, where very soon there is a proposal of 80 more machines. Right now we have only 10 machines in the country, so 80 more machines will be installed, and that NACO is very rigorously working on that part, so that there will be a routine viral load testing which will be available for all our patients also. But as of now there is targeted viral load testing. Now, who is at risk? All healthcare professionals, especially those who deal with the patients in the hospitals directly, in which staff nurses, laboratory technicians, emergency care providers, medical doctors or interns, all those are dentists, cleaning staff, surgeons, they are at higher risk of exposures. Not all body fluids are infectious unless they are mixed with blood. So blood, semen, vaginal secretion, CSF and parietal pleural fluids and amniotic fluid, these are potentially infectious fluids, not only for HIV but for the others also. But there are other body fluids which are not at risk, like tears, sweat, urine, saliva, sputum and vomitus. Unless it is contaminated with the visible blood, they are not considered as at risk. The route of transmission, we have seen this slide before, and if you focus here for this particular slide, that is needle stick exposure, that is 0.3%, and splash to the eyes or mucous membranes, it is 0.09%, while if it is injection drug use, it is much higher than the needle stick injuries. But the management of post-exposure prophylaxis, what we should do after the exposure. First thing is, do not panic. It is easier to say, difficult to practice. So messages should be very clear that if someone gets the prick, then after that what has to be done. So in the hurry, if you see in the routine setup in your own hospital, you might be seeing that then people try all funny ways of dealing with this scenario, that they squeeze, they lick the site, or they do all sort of nonsense, but all those things will increase the risk of HIV transmission or increase the risk of HIV entering into the bloodstream. So anything which causes irritation of the area, that should not be attempted. So simple plain thing will be like wash the wound and surrounding area with soap and water, rinse it well, do not squeeze, do not do any heroic things like usage of antiseptics, squeezing, and then skin washes and other things should not be done. So just put the site under the tap water and use the area, or wash the area with soap and water. That will be enough. Then if it is splash on the eye, and for the unbroken skin, wash the area immediately. Do not use antiseptic. For the eye, again, eye irrigation with water will be enough. If using contact lens, then leave them in place, while irrigating, remove them once eyes are clean, and then clean the lenses. If it is mouth, then spit fluid immediately, rinse mouth thoroughly with water, saline repeatedly. Do not use soap or disinfectant. That's what I was saying, that if someone is in panic, then they will use certain things, so those should not be attempted. It is plain soap and water should be used if it is outside the mucous area, and if it is exposed to eye or mouth, then it is only irrigation with water need to be attempted. Now, exposure can be categorized as mild, moderate, or severe exposure. If you can see here, contact with the intact skin or mucous membrane. Moderate will be with non-contact skin but large volume and percutaneous superficial exposures. Then deep cut or deep wound, and then large volumes of exposure. Then transmission of significant volume of blood, and or accident with previously used IV needle or IV cannula, that is white bore needles. Those are considered as severe exposures. For risk, again, it is being categorized as source of HIV can be HIV negative, low risk, high risk, or unknown. Negative is tested HIV negative, but we should also consider the HBV and HCV risk of transmission. Low risk is HIV positive but clinically asymptomatic or viral load very low or undetectable. High risk is HIV positive but clinically symptomatic or having high viral load. And then unknown risk, that we don't know the source, that is HIV status of the source is unknown. So this is an algorithm which can help us in determining the risk of exposure, that is exposure code. So if there is any source material is blood or blood product or infectious fluid or any instrument or contaminated with one of these substances, if that is the case, then if that is not the case, then PEP is not required. And if there is exposure to infectious fluid or potentially infected material, then we'll go to this algorithm where we'll see the risk of exposure. So mucous membrane or skin integrity compromise. Then we'll see the volume. If it is high volume, then we'll see that exposure code is 2, and if it is low volume, it is exposure code as 1. If skin is intact, then no PEP is required, and if it is percutaneous exposure, we'll again see severity. If it is less severe, then exposure code 2. If it is more severe, then it is exposure code 3. So all exposures will be coded as EC1, 2, or 3 based on this algorithm. Then the source code also is determined by using this algorithm. If source is HIV negative, then no PEP is required. Then if HIV positive, then we'll see whether the viral load is high or low, or asymptomatic or symptomatic, CD4 is high or low. If there is undetectable viral load, CD4 is high, asymptomatic, it is exposure code or source code 1. If the person is having high viral load or CD4 is very low or symptomatic, then exposure code 2. In some scenarios, exposure code will be unknown, then that will be labeled as HIV HC unknown. Now with these exposure code and source code, PEP is decided. If exposure code is 1, source code is 1, PEP is not required. All other combinations, if you see, PEP is recommended. So and the combination which we use for PEP in our national program is Tenofovir-Emtricitabine and Adherence. People who work in the program since long time, they know that earlier we used to recommend tenofovir, or the NRTI along with PIs as a third drug, and now we don't use 2 drug or 3 drug combinations. All PEP is 3 drug combination. That is number 1. Second is now the recommended regimen as per present NACO guideline is Tenofovir-Emtricitabine and Adherence, that is once a day pill, that is given for 28 days. But again, we should not forget that the PIs are considered to be better than Because see, efavirenz, the problem with efavirenz is more or less the toxicities or the side effects of the efavirenz are within the first month. So people sometimes they discontinue medicines, they have severe toxicities or side effects. So those are not people will not be able to continue them. So in my opinion, and also there is again discussions which are happening within the program that whether it should be PI which should be offered first, because the time when these guidelines were rolled out, we did not have PIs at the level of ART centers, so availability of PI drugs was a problem. But now we have PIs even at the level of ART centers, so can we consider revising the guidelines or not? But that decision has not yet been taken. So for now, the guidelines are preferred drug for PI in our national for PrEP in our national program is the combination of tenofovir, lamivudine, and efavirenz. So these are the other preferred regimen which are recommended by the not in Indian national program, but the other countries like Tenofovir-Emtricitabine plus either lopinavir-ritonavir or atazanavir-ritonavir. Again, if you compare lopinavir-ritonavir with atazanavir-ritonavir, the side effects of atazanavir will be like unconjugated hyperbilirubinemia and others, which are not with lopinavir. Only problem with lopinavir is it will have a high pill burden. So the pills will be like two times a day. Atazanavir-ritonavir can be taken once a day, like 300 milligrams tablets. Other alternatives are raltegravir, darunavir-ritonavir, and efavirenz. In children, zidovudine and lamivudine is the combination which is used and alternate along with lopinavir-ritonavir. An alternative to zidovudine can be tenofovir in children more than 10 years of age or more than 30 kg of weight, and abacavir can be another alternative. Two drug combination is not used these days, but in some countries where the prevalence is very low, they still consider two drug combination. But by and large, none of the guidelines they recommend two drug combinations for PEP. So these are the revised guidelines after which were revised in 2014. Tenofovir, lamivudine, efavirenz. Again, this is available at all ART centers as a single dose, single pill, and should be administered preferably 2 hours within 2 hours of exposure, and subsequently dose should be given at bedtime. And clear instructions to be given that it should be taken 2 to 3 hours after dinner to avoid fatty dinner. Now 2-3 things have been mentioned in this point here, B. That is, number one is efavirenz is to be given either before food or 2 hours after food, because if you give efavirenz with fatty meal, the toxicity of efavirenz will be more. If a person is having giddiness and other toxicities, other side effect of efavirenz, these are more with efavirenz if this is given along with the fatty meal or immediately after food. So that is number one. Number two, how soon PrEP should be introduced. So if the effect of PrEP or the protection with the PrEP that is PEP will be greatest if it is given within first 2 hours of exposure. So as time passes by, its efficacy reduces. So maximum time should be given within 72 hours of exposure. That is the recommended maximum time lab. The efficacy is best if it is given within 2 hours, and it can be given within 72 hours also. But what after 72 hours, what happens is you don't know about the efficacy of PrEP. Now why? Now also the duration of PrEP of PEP is 28 days. Now if you ask why 28 days, now we have very few studies in animals. Obviously you cannot again test this kind of situations in humans, because you cannot introduce HIV in someone and give PEP and see what can be the appropriate time and for having that protection. So those things cannot be done in live human subjects. So all these studies are done in or were done in monkeys or macaques, in which the efficacy of PEP was tested. So 28 days was a time which was decided after these studies, which shows that at least 28 days medications will be important for PEP. Now again, similar is the explanation for why within first 2 hours, because the risk of transmission will reduce by almost 80% if PEP is given within 2 hours. And within 72 hours, still it will be, but after 72 hours, even though you can give, but efficacy will reduce a lot. So this is the commonly asked questions by people, that if you have or if needle stick injury or any exposure is reported late, then we should we give PEP or not? There is a question: any statistics available regarding positivity after needle stick injuries? There are certain the number which I mentioned before, that is 0.3%, is actually based on the reported transmission after the needle stick injuries. So, but again, the data is very limited on this. Especially in this type, what we talked about, that is hospital or the occupational exposures to HIV, the risk has been reported as 0.3%. Unfortunately, there is not much data on this, but I think that is what is being reported since or referred to since long time. So in case there is intolerance to efavirenz, it need to be replaced with or substituted with PIs, which can be either atazanavir-ritonavir or lopinavir-ritonavir. Both are fine. Now, post-sexual assault, again, this is PEP should be provided to exposed person in case of sexual assault as a part of overall package of assault care. And in case sexual assault, as per age, weight and hemoglobin, in case of pediatric patients, all those things need to be seen in the victim, and then PEP need to be provided. Sometimes in the practical scenario, what happens is these cases are reported late, and at that time, again, there is no answer that how protective your PEP will be in that particular victim. So, but if someone comes to you and asks for PEP in those situations, it is better to give than to worry about whether it will be effective or not. So that is also true with the needle stick injuries. If someone comes to you in the practical scenario, if suppose some intern comes to you and saying that we say that it is effective within 72 hours, but if someone reports to you after 72 hours, what you will do? So what I personally would advise is give it, because again it will reduce anxiety, but explain that person clearly that even though we are giving, efficacy of PrEP of PEP will reduce after 72 hours. So it is all how you talk to those people, and it is important to do that session of counseling with those people. And actually this session will help us in understanding all those backgrounds, that why we counsel those patients in a way we usually do. If the first dose of PEP in the morning as within 2 hours, then second dose should be same night or second day. I would say that second dose should be on the second day, because again, as we know that if you consider the half-life of drugs which we use like tenofovir-lamivudine and efavirenz, it can be or it should be given once a day. If you repeat it within 12 hours again, then there will be again a risk of more and more side effects. So it can be given in the second day also. If age and weight is not fit for the TDF, then which regimen for PEP? If you are not able to give tenofovir, then because of weight, then you should be using zidovudine in place of tenofovir. But if it is because of renal toxicity, then you should be using abacavir. And similarly, if you are suppose not able to use efavirenz, you should be using protease inhibitors, as we saw in the previous slide. Then what is to be included in assessment? Again, confidential counseling and assessment of by the physician. Assess for pre-existing HIV infection by doing the baseline HIV testing. Psychological support, which is difficult but has to be given, and with all concerns need to be answered. Then documentation of the injury, and in the PEP register, which has been provided by NACO. Then special leave is required. Special it is actually a sick leave. There is no special leave as such, but leave need to be given if a person reports the toxicities or side effects of the mental health problems, especially because of the Adherence. So that has to be considered. But again, counseling is very essential in these clients or in these people. Otherwise, they do not continue the medicine for 28 days. So in the counseling, you will be talking about the risk of acquiring HIV infection. The table will help you in explaining, that is 0.3%. What is known about efficacy of PEP, I just explained on that, that is 2 hours, 72 hours, and after that, what happens? Then information on clients' risk of HIV infection, we assess the risk before, then importance of HIV testing, again explain about the window period, discontinuation of PEP if HIV test of the source patient is found negative. So that also need to be explained. Then duration of PEP, that is 4 weeks, it is important. Importance of ARV drug adherence, common side effects need to be explained before initiation. And then barrier protection or contraception, that need to be explained. Then provider should correct misconceptions during all times of counseling sessions. Then we already saw that its efficacy reduces, its effectiveness depends on how soon you initiate PEP. Best is within 2 hours, which will reduce risk of transmission by 80%, and then again baseline test and window period need to be explained. In sometimes when there is a delay in reporting, that is after 72 hours, then expert consultation will be required. But as I mentioned, that it is better to give than to worry about the risk or the benefit. Then don't delay because of undue reasons, because of which it is recommended that first dose at least should be kept at all emergency departments in the hospitals, labor rooms, and places where the risk of occupational exposure is more. Follow-up should be within 3 to 6 weeks after exposure. First is for again, or if anyone develops the signs of acute seroconversion. Then also client should be asked to avoid blood donation, breastfeeding, or if there is again pregnancy, all precautions need to be taken. Person should use again condoms and other protection to avoid any risk of transmission. If breastfeeding, what to advise? It is better to not breastfeed in that period, because if suppose a person is in window period and also if suppose gets HIV virus and is having high viral load, then HIV might get again enter through blood milk into the infant's body. So as far as possible, it should be avoided in that period of breastfeeding. In case of pregnancy status and eligible for PEP, then advise MTP or continue. Do not advise MTP. Pregnancy should be continued, and also PEP should be advised. PEP is safe in pregnancy. See, we will actually discuss in the next weekly contact session regarding PPTCT, but please remember that mother to child risk of transmission is highly reduced if viral load is very low. In cases like this, first of all, if a person is pregnant and dealing with blood or blood products which are infectious, so they should be very careful while dealing with it. That is actually the first step. And in case there is accidental exposure, then PEP should be given. And in my opinion, pregnancy should be continued. There is no question of MTP here. Okay. Then lab testing, 2 to 4 weeks, complete blood count if a person is on zidovudin. If on tenofovir, then creatinine is to be repeated after 15 days, 3 months, and 6 months. 15 days and after completion. Then week 6 HIV antibody test need to be done. Week 12, that is 3 months, and week 24, that is 6 months, HIV antibody test is to be repeated. This is PEP register, which is kept at the ART center, which need to be maintained by the staff nurse, where all details of all exposure are entered, and also This is very important, which is usually not done by the clients, that is repeat HIV testing after 6 weeks, 3 months and 6 months, and after completion of PEP that need to be recorded. So staff nurse need to follow this up. We already saw all this. Now what about the non-occupational exposure? In one of the faculty mentioned about the non-occupational exposure. One more thing, why fusion inhibitors are not used as PrEP. There is no special advantage of fusion inhibitor used as PrEP, and I don't know why this question is coming up, but fusion inhibitors like enfortumab T20 is only one in this category, and as far as PEP is concerned, again, as I mentioned, there is very limited data. There are no much trials regarding difficult regimens. So the only regimen which have been tried are the protease inhibitors, NRTI, and also nucleotide reverse transcriptase inhibitors. Yeah, those are not available also and not been studied also. Non-occupational exposure, as I was talking about, is most common type of exposure will be sexual exposure. Then risk will be assessed of acquiring infection. The less than 72 hours or more than 72 hours has passed by. If there is negligible risk, then PEP is not recommended. Again, this is not under a national program. Our national program recommends PEP only for occupational exposures and rape victims, but not for any other form of non-occupational exposure. Source patient is known, unknown, and based on that PEP is decided. For non-occupational exposure, recommended preferred regimen as far as CDC guideline goes is raltegravir and or dolutegravir along with tenofovir-emtricitabine. Possible risk of non-exposure exposure, again risk of toxicity is the same. Emergence of drug resistance we can see in the future a couple of slides, and increased HIV risk behavior. Risk of drug resistance we spoke about. It is the same, that if it is not ruled out before HIV infection, then there will be a risk, but otherwise there is no risk. Then increase in high risk sexual behavior, it is usually not seen because again it is accompanied by counseling and other risk reduction methods are introduced. WHO guidelines regarding PEP has been what again we are, most of us in the national program, most of the guidelines have been adopted from WHO guidelines. So what we are following, that is combination of tenofovir, lamivudine and efavirenz, is also recommended by WHO. So in the PEP kits, copy of management protocol need to be there. That means management protocol are to be pasted in the hospitals and the areas where there is a risk of exposure to the healthcare professionals. So PEP chart should be in the emergency departments with the information of the ART center, medical officer and the counselor, and in case of emergency whom to be contacted, that need to be written, and on the next day ART center address need to be given to the healthcare professionals so that it is easier for them to consult you all. Then necessary forms and other things need to be available. Now last section is regarding prevention with positives. As I mentioned before, that if viral load of a person is low, then risk of transmission will also be low. Now this is the study which was released in 2011, which became main source, that is HPTN 052 for the treat-all strategy. Multiple sites around the world were involved in this study, and in this there were multiple people were enrolled, and it actually compared the early initiation of ART with delayed initiation of ART. And when they did this comparison, they saw that there is 96% reduction in HIV transmission if ART is initiated at higher CD4 count in HIV positive partner of a discordant couple. So if you increase HIV, if you initiate ART in early course of illness, and the person who is HIV positive or viral load in that person is detectable to the below viral load in the person who is HIV positive goes below detectable limits, then the risk of transmission will be very, very low. So there is a 96% reduction in risk of linked transmission. So this is what they concluded, that is earlier initiation of antiretroviral therapy reduced the rates of sexual transmission of HIV and clinical events, indicating both persons and public health benefits for such a therapy. And that is why now TTOL has been rolled out in our program as well, and slowly we'll be able to bring all patients on treatment in our program also. So these